All right, we'll start over here.
I think looking at, you have to have buy-in from the very top for sure. So do you, in your core values and mission, is it there? And do all the leaders within the C-suite, do you have their buy-in or not? I think that really will determine whether or not your organization is able to implement these changes. And secondly, I come from historically black institutions where we all have different types of work to do. For example, we are trying to better care for people that are Spanish speaking, for example, at our institutions, especially in LA, where we have so many different populations and immigrant communities. So it's like everyone taking a moment to reflect internally and say, what can we do better? And we can all do something better, and to hear that from the leadership and that they themselves are also trying to better, I think creates that culture throughout the organization.
Yep, great points. Others? What can we do to facilitate changing mindsets and baking it into the system? Other thoughts?
One more that we talked about, since you mentioned patient safety, framing it that way, I think we're missing regulatory compliance, risk mitigation folks in here. I think there are real considerations that when we look at accreditation, Joint Commission, and CQA, there are real levers that we really should be mobilizing to make sure that we advance and accelerate institutional change in this space.
Other ways to sustain change?
I'm not sure about this, but I put it on the table. Get to your board chairs, through their wives, through their children, through, whatever. Get to your board chairs, whatever mechanism you have, whatever pathway you can get to them, because it's a redefinition of how unsuccessful they're being, not paying attention to this. And so you got to get that ear.
Yep. And be very intentional about how you have boards. Who are the people on your boards? Who they represent? Are they part of the community? Are they part of higher education if you're healthcare? Are they part of healthcare if you're higher education? It's a great point around board engagement.
The question, though, can't be how do we influence who gets on the board? And that's part of where we were having a discussion. We were interrupted by this.
Other people's thoughts? Yes.
So one of the things we discussed at our table is just really thinking about, if we were looking at sustainable change, to really think about who is at the table. And I think that one of the things we don't have here is members of our future workforce, and to really early engage and have them engaged in the problem solving today, so that they have that mindset as they become the leaders of the future, and so that this is a sustainable strategy.
Absolutely. It speaks to governance and what are the roles that we create at the tables for people who are newer to the system, particularly learners who actually intersect with the system in ways that are privileged. We don't have the same set of beginner's eyes.
One way to build support in the broader community is to really emphasize the connection between patient safety and health and worker safety and health, and to really get people in the general population to buy into that.
Absolutely. We talked at our table a little bit about how this is about saving lives, period, right? So we can forget everything else because it's the heart of what our mission should be. Over here.
I'll be a broken record, but Patients for Patient Safety US has identified five threats to safety. And one of the threats is that we've identified is that the healthcare system thinks that it can fix itself. And so this is we really need to help. The patient and the consumer organizations want to be part of fixing the healthcare system. That we see that the 2 decades, we haven't really, the healthcare system hasn't fixed itself. We relied on leadership. We relied on regulations and policies. It hasn't worked. We need to bring in our communities and patient groups.
Absolutely. We need to co-design the solutions with those that we serve.
I'm getting my steps in today. I think part of this is also, I mean, of course, there's the human aspect to all this, but I think tends to be this desire to only make tweaks and not change a lot. And I think and then rely on a lot of the humans doing most of the changing, and we just keep our systems how they are. And I think it may be valuable for us to even expand bigger beyond, maybe we need to really look at a whole new business model. The old business model for how we do healthcare really isn't serving our patients or our workers anymore. I think there were a lot of our healthcare workers, they sacrifice for the benefit of their patients. I'll work a little bit longer because I really want to get that done. Like, they'll sacrifice their time and their energy to try to think that that will benefit the patient in the end. But now we have patients who are losing trust in the healthcare system. We find folks who are not utilizing our healthcare system because they find it cumbersome or frustrating or far too expensive. And so I think we need to think bigger when we think about our change.
Absolutely. Yeah, thinking radically, right? Not just incrementally, and remembering that sometimes the riskiest thing to do is to do nothing. We will take one last comment before we close things out with Pam.
Sorry, my last comment. One thing I loved about, thank you for having me be on the planning committee for this, but I remember one part of our discussion near the beginning that was so meaningful for me, and I thought was very much summed up in this whole conversation today, was that oftentimes we find organizations that look at well-being and DEI as the last thing on the long list of budgets. And maybe if we have money, what's in the news this year? Maybe DEI will get more of the money, well-being will take the hit. Oh, this year it's a lot about mental health. Okay, well-being will get more money, DEI will take a hit. And I find that, unfortunately, me as a well-being professional, a lot of my DEI colleagues, we find ourselves having to beg for the same table scraps. Dare I say it so bluntly? And I think when we talk about embedding change, DEI and well-being, it's in all of our structures. It's in all of our HR. It's in all of our hiring processes. It's in our leadership development. It's in how we build our pipeline, as we all said, about the new people coming in and how we're building our leadership pipeline for people at the top and in the middle and the bottom. And I find DEI and well-being to absolutely be Siamese twins when it comes to wanting to address this issue. And I think bridging the gap between the DEI well-being conversation is crucial for success for all unified efforts.
Thanks. Yep. Tim?
No, you first.
Just really quickly, I think one thing that I want us to at least look at is how do we protect DEI professionals, especially as we see this kind of assault on, we see Black women leaders that are really are in this space. And what are we doing or what are we not doing to protect them? And then how do we make sure things like medical boards, our peer review processes, our GME committees, right, are not targeting our underrepresented minorities in medicine particularly, right? So we see that. And then there was one other thing I want to take home today is from UC Davis. We don't value community college enough. And I'm going to go back to Charles Drew, and I'm going to look at that. We don't actually, because of their screening tools, I feel like people with community college on their transcripts kind of get screened out. And yet it's the very group that we actually need. So what are the policies that will help us value community college?
I almost don't want to make my comment after that. That was a great series of comments. And now there's two things. The DEI one is because what we tend to do in all of our organizations is give DEI is responsibility of the DEI office and not see DEI and well-being as woven into the fabric of everything that we do. So people don't, like, what are you doing, Sharita? Or what are you doing? What are you doing? So supporting the people who are in the DEI office and living the DEI vision and walking that is one thing. That's not what I was going to say. And I also love the last comment that you made. So, but I will make this comment because it's about hope. You inspired me this time. 1994 was when I met Edith Mitchell. Edith Mitchell was a colleague, a mentor, a friend. She was on I was 19 years at Jefferson Medical College, most of them in Philadelphia, with Edith, who was a major oncologist. And then she was on our board. And actually, the last conversation I had with her was one of our planning meetings. Remember when she came late, and she goes, "We're having this deep conversation," and she goes, "Tim, how are you?" As she comes in late. The last face-to-face meeting we had, I was at some point talking to Vivek Murthy, the Surgeon General. Wow, the Surgeon General is talking to me. Like I can tell people the Surgeon General is talking to me. And Edith comes up on my other side to talk to me, obviously. And I said, "Oh, can you wait a minute? Because I'm talking to the Surgeon General." So I kept talking, and impatience won the day. So Edith came, wheeled her chair around here, pushed the Surgeon General out of the way, sat here, and I said, "Edith, what are you doing? That's the Surgeon General." And she said, "Tim, I'm a general too." That's right. There was never a table that Edith didn't feel she belonged on, and if she wasn't invited, she came. So the first piece is hope that we probably have more power than we think we do, and we don't use it. The second part of what Edith always did was she got to the table because she knew. It wasn't a feeling. She knew she belonged at that table. And she always brought me or somebody else who was younger or less. So one of the tricks to change, the hope we have, is that we have more power in this room than we do. And who was it that said something about the learners that aren't here just a second ago? Right back there. Let's bring the next generation here, because if we let this train derail, it's not going to happen. We are going to plant a tree, like you said, that most of us won't see the forest that grows. But we want that forest to be growing, so we have to start passing the torch and bringing other people to the table. That's our hope. That's our hope, and that's what I'll leave you with.
Yeah, so I'm going to share a quick quote and hand it over to Pam Cipriano. So there's a quote from Bell Hooks that speaks to what you were just saying, where she says, what we allow the mark of our suffering to become is in our own hands. Pam, please close us out. Thank you very much.
Wow, so many wonderful, articulate statements from the heart and as well as the brains of this incredible group. Before I try to give you some summary comments, I do want to, again, thank everybody for their active participation. I want to thank and recognize our staff for the fabulous job of putting everything together. And also to just remind us that, as you've heard numerous times, this is a long journey. And so we've just heard some incredible stories of courage and hope. And I think that's no better way to end a day than to reflect on the fact that there's a lot of positive. We all tend to spend our days thinking about the problems and the challenges and the issues and how tired we are of dealing with all these things. But I think we have been fortunate to be able to recognize and hear some very positive responses. So this session was to look at the intersection of diversity, equity, and inclusion with health worker well-being. I'm sure you sensed one of the same things that I did, which is there was this like flow back and forth between we got to do what's right for patients and what we do in our care, but really we have to start upstream and we have to make sure our healthcare workers are healthy and we're looking out for their well-being. And we sort of went back and forth, and I think that just demonstrates how linked these issues are, that you can't have one without the other. If we were to think about a word cloud from our discussions today, again, there were some really poignant thoughts that came up over and over again. And these are not in any particular order of importance, but one of the things we did start with was what really, is our goal in terms of what we're trying to achieve. And again, it is making sure that diversity and inclusion are part of what is the everyday fabric of the existence of the people that are serving our patients and that we care for as well as our patients. We also heard over and over again culture. And we know that it is the culture that will drive whether or not we are able to accomplish the ideas and agendas that we've been talking about. Respect, over and over again, that is a fundamental part of our values as well, to make sure that that is conveyed. That's part of, people being heard, being seen, and having their cultural, unique aspects really, again, recognized. We also heard about safe places and brave places, which part of our desire is to make sure that as we think about our health workers in every aspect of our teams, that they can speak up, that they can feel included, that they can, in many ways, feel like they are in a place that, again, respects them, includes them, creates that opportunity for dialogue. We also talked about shared responsibility. This is not just the individual's responsibility, just as the entire well-being agenda really relies on not only the universe of caregivers, but certainly other leaders and those that support us across the healthcare system. We need allies. That was mentioned a little bit as well, and so that role is incredibly important. We can't just beat our own drum. We have to be able to see that broaden across with a ripple effect, again, of many, many individuals. We heard radical healing at least once or twice in terms of recognizing that this is, again, this longer journey, but we may need to be even more bold. Again, courage and offering hope. So we want to be sure that we are exercising every thought that we can have that goes beyond sort of the day-to-day things that we've tried before. And I think we've got, again, great creativity. Physical safety, psychological safety, and emotional safety, again, are the characteristics we heard repeatedly as we think about those safe or brave places. Engagement and the whole aspect of data. I don't want to undersell our excellent panel that showed us that we will have information to work from in order to be able to make improvements. Now, in one of our off-the-cuff conversations that I responded to someone at our table, I said, one of the challenges, though, is that a lot of times these data don't see the light of day beyond a very limited number of people at the top of an organization. That's something we didn't talk about, but that's probably something that we all need to go back to our organizations and say, if we're going to improve well-being, if we're going to really understand that linkage to the patient outcomes, then voices throughout the organization need to rise up to say, let's shed the light on those and let's share them and let's be open. I think enlightened leadership does that, but that's not always the case. I think the point made on lack of interventions is really critical. We need evidence-based interventions, which builds on the need for more data and different kinds of research to look at all of our different caregivers and what we know or don't know. I think one of the most fundamentally moving aspects of our conversation this afternoon, though, that I don't want to underestimate is this is a human issue. And for all of those individuals that are from underrepresented or marginalized group, if we're not from those groups, so I'm in one of those people, I may not understand unless I ask questions and actively listen to those experiences, those lived experiences. And I think that's what we as a healthcare community have tried to lift up, is to say we need to understand those experiences. We need to be embracing the ways that we can have individuals, again, feel safe to speak up so that we can understand. And then, as we are helping our workforce to not only grow our diverse group, but also then be able to translate that into better care for the people that we serve. So our conversations today, I really believe, have reinforced, again, this connection between diversity, equity, inclusion, and health worker well-being. And there's lots of reasons that we want to focus on that, but ultimately it's because we are very dedicated to making sure that we provide the best care for those we serve. And as we have come to really appreciate and internalize, it's also because we know it is not selfish to take care of yourself. So I think we take that away from this day as we celebrate Healthcare Worker Well-Being Day, and hopefully for many years to come, to shine the spotlight on the efforts and successes of all of your work from the collaborative in general, but the fact that we have turned the tide in this country to really say there is momentum to make sure we do heal our healthcare system. So it's really time for us to celebrate that and recognize that every single one of you and everyone you touch has been an important part of that ongoing journey. So thank you very much, and we appreciate all you've been doing and all you'll continue to do as you go home. Thanks.